Good afternoon, everyone. Welcome to Apollo. I hope you're having a very interesting session. And I'm a surgeon. I'm a gastrointestinal surgeon, and I've been asked to talk about surgical site infections. So what I intend to do over the next half an hour or so is go through some general aspects of surgical site infections, talk about what we can do to prevent surgical site infection, and then towards the end, we'll see some of the ways by which we manage patients who develop surgical site infections. So, first of all, what is surgical site infection? And from now on, you will hear me say SSI. I mean, that's the abbreviation for surgical site infection. And how do we define it? Well, there's several definitions, but I've just picked up the two most common ones. The NICE guidance. NICE stands for National Institute of Clinical Excellence. And the NICE guidance says that a surgical site infection is a surgical wound with local signs and symptoms of infection, such as heat, redness, pain, and swelling. And in some more serious cases, with systemic signs of fever or a raised white cell count. The CDC guideline is specific about certain numbers. It calls it as an SSI if it occurs at the incision site and or deeper underlying tissue spaces and organs within 30 days of the surgical procedure, or up to 90 days if there's an implanted prosthesis. So why is it important that we are here to understand surgical site infections? So there's a bit of a background that I would like to share with you. See, it's the most common healthcare associated infection experienced by patients who undergo surgery. And it occurs in about 2 to 5% of all inpatient surgeries. So that's a fairly significant number. If you look at a hospital like ours, where dozens and dozens of operations happen on a daily basis, if we are looking at 2 to 5%, that's a significant number. So the point is, it's important that we understand that this is a significant problem and we need to learn how to prevent it. SSIs increase the morbidity and mortality, and it increases the overall cost and length of hospital stay, and it delays adjuvant treatments. I'm a GI surgeon, and when I operate on a patient, say for example, somebody with a sigmoid colon cancer, and if the patient has got well and gone home, and if the tumor characteristics, the histopathology suggests that this patient would benefit from post-op adjuvant therapy, I will be referring the patient on to a medical oncologist, and the medical oncologist will be planning chemotherapy probably in about 3 weeks' time, 2.5 weeks' time. But that can only happen if the patient has got no surgical site infections. So if a patient has got a wound which is infected, if he's got SSI, that treatment cannot be commenced, and therefore we are not able to give him the full package of cancer care. So it has it will have an impact on the overall survival. We know that for sure. The interesting thing is that studies have shown that up to 60% of surgical site infections are preventable. How are they preventable? By following strict guidelines, and that's what we are all here to discuss today. When we talk about surgical site infections, we need to understand that there are different types of wounds which occur after surgery. This is a very, very popular classification, and it will be there in almost all the infectious diseases textbook or surgical textbooks that you go through. And broadly speaking, wounds are classified into clean wounds, clean contaminated wounds, and dirty wounds. The clean wound is something where there's no inflammation, respiratory, alimentary, genital, or urinary tracts have not been entered. Classic example, an excision of a lipoma from a forearm. Right? It's supposed to be a clean surgery, and it's supposed to result in a clean wound. A clean contaminated wound is something where the lumen, the respiratory, alimentary, genital, or urinary tract are electively entered, which means it's not an unplanned entry. It's a planned entry. It's a controlled fashion, and there is usually no contamination in that maneuver. Classic example is an elective laparoscopic cholecystectomy for a non-infected gallbladder. The contaminated one is where these lumens can be entered, and there's significant amount of inflammation. And I would suggest a small bowel resection and anastomosis to fall in this category. But again, there is no gross spillage of bowel contents, and it's still in a reasonably controlled environment. A dirty wound is what you might encounter when you're operating on a patient with a perforated sigmoid diverticulitis or a perforated cancer, for example, where there's fecal spillage and so on and so forth. So these are broadly speaking 4 different kinds of wounds. And for each of these categories, there is an SSI rate, which is sort of acceptable. It's not that we want to be contented with that number. We want to keep the SSI rate to the minimum possible. We try to achieve the number of 0, but then statistics have shown that if it is a clean wound, there's a less than 2% chance of SSI. If it's a clean contaminated, there's an 8% chance of SSI. If it's a contaminated one, there's a 15% chance of SSI. And if it's a dirty wound, there's a 40% chance of SSI. Now, how do we classify SSI? We go by the layers in which the infections occur. There's a superficial incisional SSI, there's a deep incisional SSI, and there's an organ space SSI. So basically, there's an incisional SSI, so an infection that occurs around the incision, and we call it superficial deep based on the levels to which the infection has gone. So if it has gone just at the level of the skin and the subcutaneous fat, as you can see there, it's a superficial incisional SSI. If it's gone to the deep soft tissue, be it muscle or fascia, it's a deep incisional SSI. If it's gone, I'm talking about my specialty, but then this can be extrapolated to any specialty. If it's gone into the peritoneal cavity, it's an organ space SSI. For example, say if there's a patient who's had a Whipple's procedure for pancreatic carcinoma, and 6 days later or 8 days later, he develops abdominal pain, fever, tachycardia, and a raised white cell count. You get a scan done for him, and there's a large collection in the pancreatic head area. So that's a classic example of a organ space SSI. So where do these SSIs come from? Broadly speaking, there are two ways by which one can get an SSI. One is endogenous, which is what we harbor in our body, and the other is exogenous. All of us carry microorganisms in our bodies. The classic one is the nasal microorganisms. It's very, very popular. The Staph aureus, it's a topic of great discussion and debate, especially in the Western world, where Staphylococcus aureus, we call it MRSA, methicillin-resistant Staphylococcus aureus, or methicillin-sensitive Staphylococcus aureus, MSSA, MRSA. These are present even in normal individuals. If we start swabbing people in the community, people will have positivity for these kind of organisms. And these are not infections. You got to understand, these are contaminations. These are colonizations, to be precise. Colonizations can turn into infections if the environment is conducive. Exogenous is what we just heard in the previous lecture, as well as in all the other earlier lectures, I guess. Infections coming from outside, which could be the operation theater environment, the personnel, equipments, and so on. If you look at the microbiology reports of all these SSI, the vast majority of them are gram-positive cocci. About 30% gram-negative bacilli like Pseudomonas, 5% anaerobes, and we also tend to see a fair bit of atypical microbacteria, particularly in laparoscopic surgeries. The port sites, which are supposed to be well healed and absolutely fine within a few weeks' time, tend to cause problems. As a laparoscopic surgeon, I see quite a few patients who have port site discharges 2 months after a cholecystectomy, lap chole, 6 months after a laparoscopic appendicectomy. These are patients from outside, not from our hospital. They get the operations done elsewhere, and then they come to us with these discharges. And it turns out that these are mycobacterial, atypical mycobacterial, not the TB ones. These are non-tuberculous mycobacterial infections that occur because of inappropriate sterilization of the instruments in the other hospitals. And they all do very well with debridement and appropriate antibiotics, an extended course of the antibiotics. And it's also interesting to note that 60% of these microorganisms have some degree of antibiotic resistance. So what are the risk factors? Patient-related risk factors and surgery or procedure-related risk factors. So all of what you see on the screen there are risk factors. So an obese individual, an elderly patient, someone who's been in the hospital for a long period of time prior to surgery. I mean, this is not after surgery. Even the ones who have been in the hospital for a long period of time prior to surgery has an increased risk of SSI. People who have infections in other parts of the body, for example, if someone has a dental infection, it can be as simple as that. Or if someone has an infected non-healing ulcer in the foot, and he's going to have a hip joint replacement, or he's going to have a metallic prosthesis put somewhere else, or even a linguinal hernia mesh repair. These are all patients who have an increased chance of developing SSI. Surgery-related factors, these are things that we should try our best to minimize. The surgical gowns, gloves, drapes. I'm not going to go through all of that one by one, but just sufficient is it to say that that with proper adherence to the guidelines, the published guidelines, which we will come to in a minute, all of these things can be taken care of. Give the patient adequate antimicrobial prophylaxis, sterilize your equipments well, good surgical technique. That's very, very important. You may have the best instruments in the world. You may have the best sterilization and decontamination protocols, but then if your technique is not good, if you're someone who's dissecting with roughly with leaving lots of hematoma in the dead spaces, then there's always that chance that patients can get infection, because we all know that blood is a good nidus for growth of bacteria. So as much as possible, try and keep your surgical field clean. So how do we prevent SSI? Most of what you're going to be hearing from me, are going to be from these guidelines. This WHO guideline, which says global guidelines for the prevention of SSI. This very famous paper, it's a guideline, a paper which was published in JAMA in 2017 from CDC, and this one here from NICE UK, National Institute of Clinical Excellence. This was published in 2019. So they're all fairly recent guidelines that I'm referring to. And these are exhaustive papers. I recommend all of you, take note of these papers and go home and read them. There's dozens of papers there, dozens of pages. Sorry, but it's worth going through at least once so that you have an idea. And I'm just trying to summarize whatever is in there in the limited time that we have. So broadly, how do we prevent SSI? I want to categorize it into three: pre-operative phase interventions, intra-operative phase interventions, and post-operative phase interventions. What kind of things can we do? What kind of things patients can do to prevent SSI? It might sound, very, very obvious. It might sound very simple to say, but then it's important and it has clinical relevance. Patients should have a shower or a bath using soap on the day of surgery or the day before surgery. I alluded to nasal colonization a little earlier. So it's something that needs to be borne in mind. We don't swab all patients for MRSA routinely in our setup. But then it's important that you understand that there is a condition called nasal colonization of MRSA, and that can cause problems if it decides to. So remember that there is that issue with nasal colonization. Hair removal prior to surgery. I don't know if there are any operation theater staff nurses in the audience, but then next time, I mean, I want you to take it as perhaps as a take-home message today. Next time you see somebody, any of your theater technicians or you or your colleague taking a razor blade and shaving the abdomen, the hair in the abdomen prior to surgery, you can probably tell them that's not in the guideline. If at all you want to remove the hair from the abdominal wall, use a clipper, and it will have to be a disposable clipper. Needless to say, patients have to wear clean clothes when they come to theater. They have to be specific clothes appropriate for the procedure. They don't have to be sterile. I mean, these are clothes that the patients are wearing from the ward to the operating room. And the staff need to wear clean clothes, meant only for the operation theater complex. Antibiotic prophylaxis, extremely important, and something that is probably not fully understood. And let me admit, it is something that is not fully comprehended even among clinicians, even among surgeons, let me be honest. So what am I trying to tell here? The point is, antibiotics are probably overused in surgical settings. If it's a clean operation, again, let's go back to the same example that we said earlier, excision of a lipoma from the thigh or a lipoma from a forearm. There is no need for an antibiotic. But time and again, you will see patients coming to your OP, operated by others, or even you, for example, you might be doing an operation and putting the patients on 3 days of antibiotics and sending them home. It's not in the guideline. So patients will be fine even without antibiotic. It's just you feeling better when you give the patient some antibiotics for no good reason. I mean, that's not in the guideline at all. If it's a clean surgery, but it involves a prosthesis, classic example, inguinal hernia mesh repair, yes, there is a role for antibiotic prophylaxis. If it's a clean contaminated surgery, laparoscopic cholecystectomy, yes, there is a role for antibiotic prophylaxis. And of course, contaminated surgery, there is a role for antibiotic prophylaxis. And this prophylaxis, the term prophylaxis itself means that you're not treating anything, you're just preventing something. And therefore, it should not be given for more than 24 hours. And it needs to be given intravenously at the start of the anesthetic. And if it's a longer operation, it can be repeated. I get my anesthetist, who's probably going to be following me in this session. I get my anesthetist asking me when I'm doing a long procedure, a septicectomy or a Whipple's, it's almost 6 hours now since you started the operation. Can we give another dose of antibiotic? And I say yes. So that's standard practice. So the idea is if the antibiotic half-life, I mean, if the operation lasts longer than the half-life of the antibiotic, the dose needs to be repeated. So if it's on an average standard cephalosporins, if you're operating for more than 6 hours, 8 hours, it's a good practice to give another dose. In colonic surgery, we tend to give bowel prep, and the nurses do that on the ward. It's great because it turns all the solid stools to liquid stools, and there are lots of discussions that go with bowel prep, and there's advantages and disadvantages, and that's a discussion in a surgical conference. We're not going to go into the details of that. But from the SSI point of view, from the wound infection point of view, you have to understand that bowel prep given separately in an isolated fashion is not recommended. If you have to give bowel prep, you need to give bowel prep with oral antibiotics. Intra-operative phase, hand wash. The first operation of your list, you have a good hand wash with aqueous antiseptic solution, and after that, you're okay to spray your hands with the appropriate alcohol-based antiseptic. Sterile gowns, very important. And the skin preparation needs to be done just before the incision. So, I mean, rarely it happens. You don't want to be in a situation where the skin has been prepared and then it takes another 10 minutes or 15 minutes for the surgeon to put to make the incision. You don't want that. It needs to be done just prior to the surgical incision. For the preparation of the skin, an alcohol-based solution is what is recommended. An alcohol-based chlorhexidine. If that is not available, or if the patient has got some contraindications to chlorhexidine, an alcohol-based povidone iodine, which is betadine, can be used. Try and avoid pooling of the skin prep, because if you're using diathermy, that can cause fire accidents. I'm not sure how many of you have seen a fire accident. Has anybody seen a fire accident in theatre? No? Thankfully not. Okay, all right. It can be disastrous, and it's something that is preventable. If you put loads and loads of a solution on the patient's body, and if you've started your electrocautery without adequate drying, you can have a disaster there. So you've got to be really, really careful. Some surgeons use an incised drape. I'm not a big fan of it. I mean, it's a biofilm, it's a kind of a film that's placed on the abdominal wound, and then they make the incision. The idea is, everything becomes clean, and then, the wound doesn't get infected. But there's not much evidence to it, except that if you want to use it, you have to use something which is impregnated with povidone iodine. So just a plain drape is not advisable. Patient's temperature has to be maintained during the operation. It has a role to play in preventing wound infection. The anesthetist has to ensure that the patient's wound, the tissues are adequately perfused and oxygenated well, because hypoxia to the tissues is also a risk factor for surgical site infections. Good glycemic control. It is, at least in the days prior to operation, the patient's blood glucose should be well controlled. And I did mention this earlier. A good dissection technique. The surgeon needs to make sure that he doesn't leave hematomas in the wound area. Try and avoid the dead spaces. Drains. Well, it's better if you don't place drains, but then there are some operations where you have to place drains. And in that sort of a scenario, you have to ask the question every day when you go to see the patients: is it time for drain removal or not? If it's time for drain removal, not a day needs to be wasted in that. It needs to come out of the body. At the end of the day, it's an extra equipment which is going into the patient. And the earlier it comes out, the better. When the dressings are changed in the post-operative period, a strict aseptic methodology needs to be adopted. This is for the ward nurses. Many of the ward nurses haven't visited the operating room. So the amount of discipline that is shown in the operating room by the operating nurses, with all due respect, you may not see that in somebody who's not been to an operating room and who's not worked as a operating room, scrub nurse or circulating nurse. So it's our job to educate them. We need to tell them, the staff nurses on the ward, that they have to use, it starts from even, teaching them how to wear a glove and ensure that they have not contaminated themselves. If you want to clean the wound in the ward, just saline is fine. I mean, everything that I'm showing here is from the guideline. I mean, you might think, cleaning with betadine is much better than cleaning with saline, but the guideline says otherwise, right? We all know betadine is an antiseptic. It's great. Water is water, or saline is saline. Between the two, common sense says betadine is better, but the guideline says, no, it's not anything better. Just simple sterile, of course, not tap water. So sterile saline for wound cleansing up to 48 hours after surgery. And this business of putting on ointments on the wounds, I don't do any of those, because there's just no evidence for it. If you've got a wound, you've got a wound, and you've got to cover it well with just simple dressings, nothing fancy, and applying whatever ointment. There's so many ointments in the market on the wound in the operating room, and then putting a dressing makes no difference to the outcome. So despite all your efforts, if the patient develops an SSI, you've got to think as to what kind of an SSI it is. Again, going back to one of the earlier slides that we talked about, is it an incisional SSI or is it a deep, as an organ space SSI? If it's an incisional SSI, again, ask the question yourself, is it superficial or deep? If it's a superficial SSI, most of the time, I can say more than 90% of the time, just opening up of a few clips on the ward should solve the problem. It might sound a very, very trivial exercise. Patient has got redness, patient has got fullness, patient is complaining of pain in that part of the wound. Let's say it's a 15 centimeter laparotomy wound, but there's one area, maybe 3 centimeters, 4 centimeters. It's painful, it's red, it's tender to touch. And you might be thinking, oh, we need to do something really big to get this patient better. No, the answer is no. All you have to do is remove 2 clips or 3 clips in that area where exactly the problem is. And you will see that all of those signs of inflammation or symptoms of inflammation go away within 24, 36 hours, even without antibiotics. Remember, this is the same patient who had prophylactic antibiotics, which we stopped 24 hours after the operation. And we are now on the, let's say, 10th day. You don't want to start the patient again on antibiotics because you know for sure this is a superficial incisional SSI. And the treatment for superficial incisional SSI is opening of the wound or removal of the clips. If it's gone to the fascia or to the muscle, yes, there's a role for antibiotics. If it's gone even deeper, again, the example that I gave you earlier, Ripple's procedure, pancreatic carcinoma, a collection 15 days later or 10 days later, just opening up the clips or antibiotics is not going to solve the issue. You got to do what is called source control. And what is the source here? The source is an infective collection in the peritoneal cavity that needs to be drained. Rarely, the patient will have to go to the operating room to achieve that source control. CT-guided drainages, ultrasound-guided drainages might achieve source control, but there will be occasions from time to time where the collections are thick or perhaps not accessible, and the patients will have, or perhaps there is some dead tissue there, which is not going to come out on its own, and you may have to take the patient back to theatre for further debridement or surgery. So I'm not sure if you can see that well, but that's just a summary of how you treat SSI. So basically what we've been saying the last few minutes is what is summarized here. So if the patient has got pain, tenderness, erythema with systemic infection, suggestive of a superficial SSI, and if it's less than 5 centimeter, just open the wound. If it is more than 5 centimeter, you still have to open the wound, but then you will have to consider antibiotics. If there are systemic signs of infection, and if the patient has got fascial layers involved, and if it's a deep incisional SSI, you will have to open the wound, you will have to give antibiotics, and you may also have to consider, getting rid of the infected tissue, possibly debridement. If it's a deep SSI, antibiotics, opening up of the superficial wound, but then you have to understand the infection is coming from deep within. That needs to be addressed. And in a setup like ours, we have excellent interventional radiologists, and when we know that there is a collection, a deep collection somewhere, a drain is placed, either an ultrasound guided drain or a CT guided drain, and the patient gets better remarkably quickly. So in summary, what I would like to say is SSI is a small but a significant cause for morbidity and mortality after surgery. It has an economic burden. Remember, patients have to leave in a planned fashion, leave hospital and go back home and get back to their normal routine. And if a problem in the wound is going to either keep them in the hospital for long or keep them at home for long without allowing them to get back to work, that's going to have a huge financial burden on the patient, on the patient's family. So it's not a trivial thing You might think, oh, it's just a wound infection, or it should be all right. But then these things don't allow patients to get back to their normal lives. And again, going back to that example that I gave you earlier, the cancer patients, if they have SSIs, they can't get on with the next phase of their treatment, which is adjuvant chemotherapy. So all of these things are important. So why do these SSIs happen? It's multifactorial. It's not just one issue. It's not the equipment not getting sterilized properly in the operating room. It's not the lack of education of the nurses. It's not the surgeon who's not meticulous in his handling. It's not the CSST not delivering proper sterile cloths and things. No, it's a combination of things. When we're talking about infection and infection prevention, the buzzword is bundling, and you heard that word being said in the previous talk as well, bundling. So when all of these things work in tandem, the result is phenomenal. But if any one or two is not in that bundle, you may not get the full benefit of whatever is left over in that bundle. I hope that makes sense. So if there are say 10 things that you need to do to achieve 100% success, leaving away 3 may not necessarily give you 70% success. Leaving away 3 may give you 5% success. That's the concept of bundling. You need to do everything together to get that result. And how do we get to that stage? It's through educational programs like these. But then it's not just about coming for a program and listening and going away, but it's also some effort from individual side. One needs to go through the guidelines. You don't have to remember each and every part of it, but then at least you should be able to understand what the summary of these guidelines are. The 3 guidelines that I showed you on the slides should be a good good set of information for you to go through. And for a surgeon, I think it's, in addition to knowing all these matters and reading all the guidelines, it's very important that the general principles of physiology are always taken care of. The wound care is meticulous, and the surgical technique is up to the mark. So with those few words, I would like to conclude my talk. Thank you very much for your patient listening. I'm happy to take questions if there are any.